We are live.
Very good evening, everyone. Welcome to iFocus Online Lecture 266, Uvea Module number 7. Today we have with us Dr. Aniruddha Agarwal from Cleveland Clinic, Abu Dhabi, talking to us on ancillary investigations in uveitis, part 2, which includes UVM, ultrasound, OCT, and OCT angiography, which is a case-based interactive session. We have panelists today with us, Dr. Amod Gupta sir, Dr. Jyotirmay Biswas sir, Abhilasha ma'am, and Parthopratim sir. I invite Jyotirmay Biswas sir to please introduce Aniruddha sir to our audience.
It's indeed a great pleasure and privilege for me to introduce Dr. Aniruddha Agarwal. And he is basically from PGI Chandigarh, did the residency, and he is now in currently Associate Staff Physicians, Medical and Surgical at Uveitis at the Cleveland Clinic, Abu Dhabi. He completed Clinical Research Fellowship at the Stanley M. Trusland Eye Institute, Omaha, Nebraska, between 2014 to 2016. He authored more than 240 publications and 40 book chapters, and he received the prestigious Kataria Memorial Gold Medal from Prime Minister of India in 2014. He is one of the most promising and talented uveitis specialists I've ever seen in from my career, and he has done a seminal work on imaging, particularly in uveitis imaging. And I look forward to listen to you, Aniruddha. And over to Aniruddha.
Thank you very much, sir, for the kind introduction. It's a very humbling experience to be here with Professor Amod Gupta sir, my teacher, my mentor, from PGI, where I have learned everything in retina and uveitis. And thank you to the team iFocus for this opportunity. So in this next 1 hour, we'll be going through the part 2 of imaging, and previous the iFocus session was spoken by Dr. Padmamalini Mahendradas ma'am, where she covered important topics of fluorescein, ICG, and other wide field imaging. So I'm going to share my presentation, and if you can please confirm that it's visible.
Yes, sir, it's visible,
Okay.
sir.
Thank you. So I'm moving on straight away to ultrasound in uveitis. So I'm going to talk about very specific indications where now you use ultrasound in uveitis. Remember that ultrasound is a very technique that has been there for quite some time with all of us. And we must not forget to use ultrasound in the clinic, because there are very specific conditions where ultrasound is sometimes the only modality which can help you decide treatment for the patient. So it has an important decision-making value. These specific indications are, for example, media opacities or secondary cataract, assessment of, for example, if you have a retinal detachment or a choroidal detachment, and of course, when you have inflammatory lesions like cysticercus, and looking at suprachoroidal or even sometimes supraciliary fluid and choroidal thickening. I've put choroidal thickening at the bottom now because now we mainly depend on the EDI OCT to look at choroid, especially if the media is clear. But when the media is not clear, we have to depend on ultrasound. Now, in general, the echoes on ultrasound are divided into the following. So they could be dot-like, point-like, or pinpoint echoes. You have membrane-like echoes, you have cystic echoes, and you have solid, or like in cases of masses. Now, there are specific case examples where you would like to see the ultrasound picture when the media is opaque. And often in patients of uveitis, you would like to see the involvement of the posterior segment, especially the vitreous and the retinochoroid. And in many instances, you realize that there is a vitritis and a posterior vitreous detachment. And looking at the posterior vitreous detachment becomes very important in these patients, because sometimes you might confuse them with retinal detachment. And in patients of uveitis, you could have either an exudative retinal detachment or you could have rhegmatogenous. But in general, the incidence of PVD is very common in eyes with uveitis. So you must be very well versed looking at PVD and differentiating it from retinal detachment, either exudative or rhegmatogenous. Now, when you have rhegmatogenous detachments, the rule of thumb in general is that the retina will be attached at the edges of the optic nerve, and it will be, of course, having a specific configuration. If it's an open funnel, you will see like a sleeping V pattern where attachment is at the optic nerve margins, and it will not be detached from that particular area. And sometimes you can have a schitic-like detachments in patients with uveitis, especially if you have patients with viral retinitis and the view is very bad. You can look at the peripheral ultrasound scans and you can see that sometimes the retina could have this kind of an appearance where you have these white arrows showing you almost a double layer sign where you have vitreous adhesions at the peripheral retina. Again, if it is a child presenting with uveitis, sometimes children have severe uveitis, one eye is already lost, and you realize that if you find such a mass in the child in the middle, it's actually nothing but a closed funnel retinal detachment, and you will realize that there'll be a very small area where you can see a stalk-like connection to the optic nerve. So this often confuses us, but you must do a complete examination looking at all positions, and you will realize that this is, especially in children, can be very confusing. Moving on, you have a presence of vitreous hemorrhage, which is an important differential diagnosis, especially when you're looking at eyes with endophthalmitis. So a vitreous hemorrhage could have associated proliferation at the disc, and this becomes important in conditions such as Eales disease or occlusive retinal vasculitis, which can present with neovascularization. Now, cysticercus, and you have plenty of case examples that you can see where cysticercus can be either in the vitreous cavity with the scolex that is very clearly visible, or it can be subretinal, or it can be even in the muscle. So you could have number of locations, and you must be aware how to change the probe, whether if you want to look at the orbit or if you want to look at the vitreoretina interface. So you could choose your probe accordingly. And in general, we start off with either a 10 or a 20 megahertz probe. And if you want to look at the orbit, you can even use the 5 megahertz probe to look at the location of the cysticercus. It could be under the muscle as well. Now, choroidal detachments are very important components of eyes with uveitis. And in general, if you have a choroidal detachment, that means there is a posterior segment involvement and patients might need more aggressive treatment. Of course, it depends case to case. So moving on, in children, when you are suspecting large cells floating in the vitreous and the anterior chamber, you could have an underlying mass lesion. And these could be a retinoblastoma in children presenting or masquerading as uveitis. So in such situations, keep your eyes open, and ultrasound showing calcification is really important in these patients. Now, I think one of the underutilized entities in our clinic is UBM. And UBM is a non-invasive technique which gives you very excellent images really for the ciliary body. And even the anterior segment OCT does not give you as good images of the ciliary body like the UBM. So UBM still has a very specific place in the clinic. And the ciliary body imaging, I don't think we still have modalities which are optical based better than UBM. So I find UBM very useful in patients with opaque media, especially those with hypotony. If you want to detect cyclitic membranes and ciliary body atrophy, UBM becomes really important. In addition, so this is a normal UBM where you can see the normal structures, the iris, and this is the normal appearance of the ciliary body that you can see. And of course, you can have certain situations where if you have vitritis, in fact, the the anterior chamber cells, you can see them floating so nicely on the UBM image. So UBM can also tell you if there is a ciliary body swelling. So this particular patient, if you see in some of the scans here, so there is a ciliary body swelling over here. Of course, you have to measure it. You have to pause the video, look at the normal eye, the contralateral eye, and see if there is ciliary body swelling. The swelling of the ciliary body or increased dimensions of the ciliary body become very important when you are looking at eyes with JIA. One of the things in the previous lecture, Professor Amod Gupta sir mentioned is laser flare meter. If you have access to laser flare meter, it's a very important tool to monitor eyes with JIA. And if you don't have access to laser flare meter, then I think periodic UBM analysis of ciliary body dimensions can actually be a very good surrogate marker of inflammation. So if you continue to have ciliary body inflammation along with cells or other manifestation that is a very important marker of ongoing inflammation in JIA eyes. Moving on, so this is some hidden structures that you can see on UBM. So sometimes parasitic or other inflammatory cysts can be present very remotely, like under the iris, and that's the only way you can see is by doing a UBM. And of course, supraciliary fluid. So if you have patients with supraciliary and suprachoroidal fluid, these are eyes which have severe uveitis, and so I think you must pay attention to these entities also. So in general, like I said, uveal swelling has profound importance in management of the disease. Ciliary body atrophy or cyclitic membranes have become very important to detect especially when you're planning surgical intervention. So in eyes, again, I come back to JIA, and when you have children with JIA and you need to plan any surgical intervention, even a simple cataract surgery, I would always do a UBM to look at the ciliary body status. Because if there is a ciliary body atrophy, any surgical intervention can predispose to persistent hypotony, rhegmatogenous detachments, and retinal breaks in these eyes. And so looking at the ciliary body is very important. Supraciliary or suprachoroidal fluid becomes important marker of inflammation, especially if you have stromal choroiditis like PKH, they can present with this entity. Even entities such as uveal effusion syndrome or endophthalmitis can have this amount of fluid. So it's an important marker of inflammation as also of panophthalmitis. Now we are getting new therapeutic agents such as the suprachoroidal injection of triamcinolone. It has been approved in the US. I think soon it might be approved in Europe, which is a triamcinolone called UTIC, which is injected into the suprachoroidal space. And also there are trials going on of suprachoroidal anti-VEGFs. So I think the suprachoroidal space is going to become an important area where therapeutics can be injected. And so imaging the suprachoroid is very important using UBM and ultrasound. I'll move on to OCT. There is really a lot to talk about in OCT and OCT angiography. I will focus on both OCT and OCT angiography together, and I will take few entities covering the most important entities. Of course, I may not be able to cover the entire spectrum of uveitis, but in general, when you have a certain phenotype of the disease, you can use the same principles. So, for example, in patients of toxoplasmosis who present with necrotizing retinitis, toxoplasma has important OCT features which help in the clinical diagnosis, especially when you are faced with a situation where the view is not clear and you have a retinitis lesion, you're confused between infective, non-infective, viral, toxo, etc. So in general, when you have a simple straightforward case like this one, where you have a retinitis lesion right in the center with vitritis in a young patient, clinically, of course, we will go ahead with the diagnosis of toxoplasma, but looking at the OCT becomes very important. So the fluorescein, of course, shows you leakage, but it may not be very contributory. But the OCT shows you, even though the view is very blurred, you see that the choroid is thickened and there is a necrotizing retinitis on top of the choroid. In what I mean by necrotizing retinitis on OCT is that there is complete disorganization. There is in general a hyperreflectivity, and you cannot see different layers from each other, and there may be fluid accumulation. This is classical presentation of toxo. So this patient, again, once you treat with intravitreal or systemic treatment, that's a different topic altogether. But whatever the way you treat, I think following the patient on OCT becomes very important. And you see that first thing to improve will always be the vitritis and the retina. The choroid will eventually come back, but the choroid may actually take long time to become normalized and its thickness to become normal. I think OCT can be really useful as a marker of continued inflammation, because often we are faced with the task of when do you would like to stop steroids and antibiotic in patients of toxoplasma. So I think, of course, looking clinically at the lesion for the pigmentation is one way and overlying vitritis. But I think OCT also normalization of both the retina and the choroid can be considered as a useful marker and could help you decide when to stop antibiotics and steroids. In general, when you have a toxoplasma, as I said, just to recapitulate, we have retinal thickening, disruption, and the choroid is involved. So the involvement of the choroid and presence of vitreous cells with thick hyaloid is an important feature. Sometimes you have these stalagmite-like deposits on the surface of the retina, and they have mirror-like deposits on the hyaloid. Often in eyes with toxoplasma, if you do the OCT, you will realize that there is a vitreous schisis, and you have these inflammatory deposits on the retinal surface. Now, these retinal deposits are not specific to toxo, but they could be there in viral, but they represent exudates which are accumulating on the retinal surface. So they are not actually carrying the parasite in them. This is another patient here, 2 cases where you have the involvement of the choroid. As you see, the complete choroidal architecture is disrupted. Of interest, if you really look carefully, and if you are interested in imaging, you will realize that the extent of choroid laterally is more than the involvement of the retina. And that means the choroidal involvement is probably slightly more in the area compared to retina. And if you correlate it clinically, you will realize that all lesions of toxoplasma have a central yellow necrotic core surrounded by slightly orange area, which is more deeper or involving the choroid. Now, there is thickening of the choroid and the choriocapillaries will not be visible. In contrast, if you look at viral retinitis, you will realize that viral retinitis also can have lots of cells. So sometimes if you have immune recovery, or if you have with the heart therapy, if the CD4 counts are near normal, a lot of patients of CMV or even viral retinitis nowadays, they present with a lot of cells. But you can see that despite so many cells, the choroid is almost completely intact. And this becomes a very important marker. I feel it's very important as probably the lab markers, serology, because the serology itself is also not confirmatory, but an OCT can show you that the choroid is not involved. In general, I follow this algorithm. When I have a patient of necrotizing retinitis in my clinic, when I think it's viral, so you have to rule out the blinding disease first. So rule out viral and toxo. If the lesion is amenable to OCT, the first step I do is always OCT. And if on OCT, if you have a peripheral lesion where you have full thickness retinitis with this cavernous pattern, I know that this is a patient of viral retinitis. And these patients of this cavernous pattern where you have this retinal elevation and bridging tissue that you see on the left side, these are patients who will eventually detach. And in fact, this case example also detached. And so we are now working on identifying these patients with this peripheral cavernous-like pattern. And these are patients who will probably benefit with early intervention, such as laser or even prophylactic vitrectomy. Those lesions which are not amenable to OCT, of course, we will do fluorescein angiography and look at the classic signs of viral retinitis. But of course, we must keep in mind that these patients could also represent atypical toxo, lymphoma, and so many other differentials. There is an entity called punctate outer retinal toxoplasmosis. So this is a case by Bailey-Freund, who shared with me a patient of a lesion. It's a variant of classic disease. These are outer retinal lesions alone of toxo. Often they can come and go without noticing, but sometimes they can then eventually develop full thickness retinitis. So in fact, this patient presented with a lesion shown by the blue arrow, which on the OCT angio, you can see that there is flow deficit, but this patient actually progressed to full thickness retinitis in the parafoveal region. So port could be like a satellite lesion of toxo, or it could eventually progress to full thickness necrotizing retinitis. So I'm going to the next part, which is another patient with metamorphopsia. And we briefly mentioned about this in the previous lecture also. So here you have birdshot lesions in this patient near the disc. So you see these yellowish or lightly pigmented lesions which are distributed throughout the fundus. Now, if you look at these patients, and if you look at the fluorescein angiography, they are often studied with these nodular lesions. There is lots of vasculitis. Most often these patients are HLA A29 positive, and they have diffused leakage of the disc and the vessels. Now, birdshot is a very difficult entity to control, because when you have a patient of birdshot, the clinical picture is going to show you something else. ICG is going to show you something different. Fluorescein will show you a different level of inflammation. And it's a bilateral vision-threatening condition requiring lots of immunosuppression. So I think birdshot and Behçet's, these are two very difficult entities And birdshot is even more difficult because you need to have Goldman, the visual fields, you need to have fluorescein, ICG, OCT, so many imaging modalities to understand really what's going on. If you look at the OCT, often these patients will have epiretinal membranes and macular edema. They present mostly with macular edema. And in these patients, it's a bilateral disease. So if you have macular edema in these eyes, usually they require systemic treatment. And I start with steroids and then quickly start the immunosuppression. Often, we can go ahead and do the OCT and OCT angio to look at the alterations. And the OCT really helps in monitoring the response. So of so many options that you have in the clinic to monitor the inflammation in birdshot, I think OCT is very important because it shows you the level of macular edema. If your macular edema is settling down, that means the patient is on the right track. The birdshot lesions itself may not go away. And even if you look at the ICG and fluorescein, they may continue to have these hyperfluorescent lesions. So I think Goldman visual fields and OCT, they form very important markers of inflammation in eyes with birdshot. And so adequate dose optimization or changing immunosuppression, OCT becomes a very useful marker. So of so many white dot syndromes, OCT plays a very important role, not only in identifying the white dot syndrome, but also sometimes differentiating between these white dot syndromes. So this is a classic patient from Asian countries. India has a number of lesions of serpiginous-like choroiditis. And you see that some lesions are active on fundus autofluorescence. But what's of interest is, especially when the lesions are in the macular region. Now, when you have macular serpiginous-like choroiditis, you will realize that these lesions are very easily visible on fundus autofluorescence, no doubt about it, and you see the activity. But when you do fluorescein and ICG, you will realize that on fluorescein, the lesion is not so clearly visible because it's a macular lesion. You may miss it. It's hypofluorescent, so it can be mixed with the foveal avascular zone. But ICG is very useful in showing you the hypofluorescence on ICG, which shows basically means that there is a choriocapillary ischemia. And if you do the OCT angiography, we have shown before that it exactly co-localizes with the ICG findings. Now, I must admit that all of the hyporeflectivity on the OCT angio is not choriocapillary ischemia. There is a component of shadowing or an artifact, but there is definitely a true ischemia as well, as you can see on the ICG. So you can see choriocapillaritis inner ischemia corresponds to ICG. And when you have these patients on follow-up, you don't have to always do ICG. And you realize that this is how the patients heal. And the ICG is almost near normal. And if you look at the OCT angio, you will see that it's almost normal also, but you have some disturbance in the choriocapillaries, which might persist for a long time. Now, we have actually shown that lesions which are less than 0.1 millimeter in size, the choroiditis lesions less than 0.1 millimeter in size at baseline, they will resolve with minimum flow voids. So in fact, what I've started to do now is avoid letting the lesions increase in size. Try to target them early. So if you have macular or a peripapillary serpiginous-like choroiditis, I usually do not hesitate in going ahead with a corticosteroid implant in the eye because the response is really rapid and you have minimum flow void areas at the follow-up. Now, if you look at the OCT angio, you can use OCT angio in the clinic to show the patient and yourself how the patient is improving during the course of follow-up. And in fact, if the patient has any subclinical recurrence, you can detect it very well. Of course, now this is just a 3x3 millimeter scan, but if you have access to Plex Elite or other machines, you can do much larger montages and even go into the mid-periphery and see them. Now, if you belong to a clinic where you don't have access to OCT-A, of course, you could do fundus autofluorescence and equally kind of manage the patients very well. But it's important to understand the differences in the information which is being provided by the machine. This is my algorithm that I follow. So when I have a patient of serpiginous-like choroiditis, fundus autofluorescence, I think, is the most vital because it gives you the activity immediately. Almost immediately, you know that you have some lesions, let's say in the panel D, within the circle. These lesions are fuzzy, white, and they are definitely the most earliest manifestation of TB serpiginous-like. Whereas the lesions that you see by the yellow arrowhead, they are more black over here, and this is the last stage of the TB. And so between this, there you have the chance of intervention. So fundus autofluorescence straight away gives you a very good view. And the OCT, of course, shows you disruption of various layers depending upon the disease situation and RPE elevations. Fluorescein ICG, I think I do only at baseline nowadays in patients of serpiginous-like. And of course, if there is any situation where there is a paradoxical worsening, or if the patient is non-responding, you suspect resistant bacteria, or you suspect non-tubercular mycobacteria. In these special situations, of course, you can do invasive angiography at any point. And OCT angio, I think, is useful if you are suspecting an underlying choroidal neovascularization, or if you want to serially image the hyporeflectivity. But it's not mandatory. It's not mandatory to do any of the OCT angio or the latest tools that I'm talking about. You can very well manage the patient just by fundus autofluorescence and OCT. Now, the placoid type of chorioretinitis, I think the ICG and OCT angio play a very important role. And I will first explain to you the ICG, and partly this has been covered actually by Padmamalini ma'am. But if you see the first box and the blown up image, this is during the active stage. During the active stage, you realize that the ICG on the border of the lesion shows you a distinct hypofluorescence. This is an activity. This is choriocapillary ischemia, which is progressive at the edge, and it exactly corresponds to the OCT angio. When the lesions heal, the ICG shows you that this kind of a pattern where in the center you have a mishmash of residual choriocapillaries, but that leading edge is almost gone. Now, I would like to make two important points. One point is that ICG is not the definitive imaging modality that tells you healing of the choriocapillaries. It can give you a clue, but it will not definitely tell you that the choriocapillaries has healed. But this is how the healed pattern will look like. If you have atrophy of the choriocapillaries, the atrophy will look somewhat different from this active lesion. The atrophic areas on ICG will be completely dark. And remember, the choriocapillaries, when they atrophy, they will atrophy in a specific manner, not in a linear manner like this, like on the top. They will have a mishmash arrangement of atrophy with residual choriocapillaries, and this is how it looks like. But even in the placoid disease, you realize that autofluorescence, is giving you such a beautiful information, shows you the active edge, shows you healing very well. And the OCT angio parallels that to the ICG and autofluorescence. So you don't have to do all the imaging modalities, but you have to understand what each modality is showing you. This is a patient who presents with metamorphopsia. Now, with so much of things going on, it's very easy for us to believe that this is probably, the scar or the fibrosis has extended. And definitely you can, in a busy clinic, send the patient away. This is where the OCT angio comes very, very critical and handy, I believe, in TB serpiginous-like. So if you do the OCT, sometimes the OCT alone is enough because you find that there is a subretinal hyperreflective material or SHREM, and on the fluorescein and ICG, you don't find much. Okay, but if you do the OCT angio, you see such a big network, which is visible under the fovea. And this kind of a network, you can of course look at the blood supply and you can argue if it is coming from the choroid or intraretinal, but for sure you can see the neovascular membrane and you can define the network, which you cannot define on ICG and fluorescein. So the sensitivity of OCT angio, and this was a question asked again in the previous lecture, what's the sensitivity and specificity of fundus autofluorescence, which is a difficult question to answer. But easier question to answer is the sensitivity of OCT angio is almost 100% when you want to detect a CNV. The specificity, I would say, is over 95%, distinguishing it from inflammatory lesions, which means if you have an inflammatory lesion of, let's say, punctate in a choroidopathy, or if you just have a bump of choroiditis, to differentiate that bump, whether it has an underlying CNV or not, OCT angio can have a specificity of 95%. Sometimes you have a subretinal hyperreflective material, but you have no flow inside. And that is also normal. And you can monitor those lesions using OCT angio. Now, this is a patient which we may not see so much in the Asian countries, but it's very common in the Caucasian population, the retinal flu or the choroidal flu, they call it. It's called, it's an entity where you have, I'm sorry, this is MPE, but I'll come to mutes. But in this particular entity, which is MPE, is a condition, again, which is very similar to the multifocal choroiditis or serpiginous-like choroiditis spectrum, where you have hypofluorescence on ICG and ellipsoid zone and photoreceptor disruption with a placoid lesion. And these patients have a very classic presentation on ICG, and the OCT angio shows very similar findings like what I just described in TB. So MPE has placoid pattern of choriocapillaries flow deficit. This is a patient of VKH disease, and VKH is again a very important entity that you can image using OCT and of course fluorescein and ICG. Recently, there has been a lot of interest in looking at the OCT layers in patients of VKH, but one point of caution is that actually a lot of the OCT findings have already been described in VKH before. So if you really dissect the OCT in VKH, two main things come out. One is that you have compartmentalization of fluid. So most patients of VKH will have accumulation of fluid in the intraretinal and outer retinal space. So this compartmentalization of fluid is one characteristic. The second characteristic of eyes with VKH is presence of choroidal stromal granulomas, which are distributed diffusely in the choroid with choroidal thickening. Now, unlike a TB choroidal granuloma or the toxoplasma, the choroidal granulomas of VKH may be difficult to visualize on the OCT. And there are many reasons, because the fluid may be a lot and the granulomas are so randomly distributed, you may confuse them for blood vessels. Important thing is to differentiate VKH from CSR. Now, remember, when you have compartmentalization of fluid, we believe that this happens because of sudden rush of inflammation, which is the most important feature of VKH. So when you have a sudden accumulation of fluid, you have a break which develops in the outer photoreceptor layer, and this is called as the bacillary layer detachment. The term bacillary layer was given by Bailey-Freund and colleagues, but remember, this bacillary layer detachment is not new. It has previously been described in other entities, and it was in VKH as well. It was termed differently, but now we go with the flow and we call it bacillary layer detachment. And eyes also with toxoplasma and other conditions such as trauma and underlying inflammation, CSR, they have been shown to have bacillary layer detachment. Now, bacillary layer detachment can not only happen in eyes with VKH, but they can also happen in or in eyes with inflammation, but they can also happen in eyes with non-inflammatory conditions like CSR. Remember, whenever you have an acute accumulation of fluid, like a condition like trauma, even then you can have bacillary layer detachment. So bacillary layer does not give you any diagnostic information. It's just a manifestation on the OCT, and it tells you that once the bacillary layer improves, it's that point where the visual recovery takes place. So moving on, I think TB and sarcoid granulomas are important entities which now you can differentiate on OCT. And this is a patient where you can see a very impressive choroidal granuloma. And this is a large choroidal granuloma. We call it tuberculoma, and it is present under the in the choroid over here in a patient. And you realize that in this patient, there is a large hyporeflective lesion involving almost the entire choroid without any visible choriocapillaries. Over here, you find that there is there is an outer retinal kind of an infiltration, and this outer retinal infiltration is a very important characteristic of TB. When you are faced with a choroidal granuloma, remember that your labs become very important. You need to rule out TB, and you need to decide whether the patient has TB, syphilis, sarcoid or even VKH. Most commonly, we differentiate between TB and sarcoid. So if you have a TB positive, of course, you have to start antitubercular treatment. And I think the labs and the OCT findings both become really important. But it's not just the OCT, of course. You have to look at the presentation. TB usually present with lobulated, single large lesions with a lot of vascularization. And sometimes they can present with neovascularization at the disc or right on top of the granuloma. And the neovascularization in TB has been very well described now by Dr. Soumyava, Basu, and anti-VEGF treatment in TB has also been described a lot already, and we use it as an adjunct. Recently, ANG2 inhibition by faricimab has been approved, and the PGI group has also shown the ANG2 levels are very high along with VEGF in eyes with TB. So probably we can target them with newer agents as well. So this outer retinal infiltration differentiates TB from sarcoid very well. Sarcoid granulomas are usually very well circumscribed. Like in this case, they don't present with much fluid. You can occasionally have vascularization in sarcoid also. My colleague in Cleveland, Francesco, has published one case of vascularized sarcoid granuloma. So it's not an absolute truth that only TB can present with vascularization. You can have vascularization even in sarcoid, but that's quite rare. Usually sarcoid granulomas present something like this, with multiple granulomas studded everywhere in the fundus. So sarcoid granulomas are usually more rounded. They're not very lobulated, and they may not have as much fluid or exudation like TB. Syphilis is one entity where again OCT becomes helpful. Now, each topic is a subject by itself, but I can tell you that in general, syphilis has three manifestations. You can have syphilitic preretinal accumulation, multifocal syphilitic retinitis, and syphilitic retinochoroiditis. So in general, the preretinal accumulations of syphilis look very similar to the stalagmite-like deposits I showed you in toxoplasma. But they can also be, they are usually preretinal, but they are multiple, and they're very large. So the fundus image over here shows you multiple large accumulation, almost like cotton balls, like of that in Candida. But you can see them in syphilis as well. The multifocal syphilitic retinitis lesions are more white. They are more deeper in location. They almost involve the complete thickness of the retina. And they are multifocal, distributed usually in the periphery and mid-periphery. Syphilitic retinochoroiditis are usually a very confluent lesions. They can have the placoid appearance or confluent appearance. The placoid appearance is characteristically called ASPPC, in which you have these bumps of the RPE, and you have hyper-autofluorescence in the central particular area. And then progressively, there is a kind of a target-like appearance where you have photoreceptor atrophy. So you have various patterns. The ground glass pattern of syphilis is of a lot of interest, and you will find a lot of papers telling you about the ground glass pattern. And the ground glass pattern has a characteristic appearance on fluorescein angiography. But in all of these, I think OCT plays a very important role in showing you the different manifestations of syphilis. Moving on to dengue. Dengue retinopathy on OCT has been described very well. You can have these conical elevations, you can have vitreous cells, you can have fluid, and this kind of appearance is very classic of dengue. And when you have the macular involvement or foveal involvement with this kind of a picture, you can suspect any RNA virus infection. In fact, even chikungunya can have this presentation where you have a retinitis and you have intraretinal fluid along with disruption of the outer retinal layers. In dengue, usually the choroid is paired, and it's usually only a retinal disease. If you look at the OCT angio, both of chikungunya and dengue, you will realize that there will be a loss of the superficial capillary plexus with irregular vasculature. Chikungunya eyes can actually have more retinitis component. And the Narayan Netralaya group has very well talked about the post-fever retinitis, which are classic presentation after a few weeks of fever. You have a febrile illness, you have retinitis lesions, usually in the posterior pole or in the mid-periphery, and they can be associated with loss of the capillary plexus circulation could be a component of signal loss, could be a component of true loss as well. There could be a significant loss in the deep capillary plexus, and the deep plexus loss is a very important feature of dengue. And this is more prominent than the superficial. So with this, I think we have covered most of the aspects of the OCT applications in the clinic. There are some applications that we haven't talked about, which include fungal lesions, candida lesions. There is an ongoing research that we are conducting, differentiating candida and aspergillus presentation on the OCT, but often they also present with sometimes with full thickness necrotizing lesions. And they could also have overlying vitritis with a rain cloud sign appearance on the OCT. So with this, thank you once again, I focus, and I'm very happy to take any questions.
Thank you so much, Aniruddha sir, for that wonderful talk. I think the images that you shared were like really amazing and like case-based. Ma'am, Parthopratim sir, Abhilasha ma'am, can we take questions?
Yeah, let me, I just, thanks Aniruddha, it was a wonderful, as usual, we are expecting a fantastic lecture from you. So I would just like to start the discussion with a question, because Dr. Gupta and Dr. Biswas is here. So do we need to perform imaging in all cases of posterior uveitis?
I don't think we need to do everything. So I think the important message is you have to understand what you're doing and why you are asking, because you might get information which you don't know what to do with it. So you have to look for certain conditions. And when you have a patient in front of you with posterior uveitis, I think you should immediately have few differential diagnoses in mind. And there are some things that you would like to rule out or rule in. So a basic fundus imaging, and sir is an expert and sir would tell you, is important in documenting the findings and recording the findings for you. And let's say if you're not in the clinic anymore, you have another clinician following the patient, you have a photo which is documenting the findings. But depending on the lesion of posterior uveitis, you can choose. You can do autofluorescence, you can do fluorescein angiography, or you can do wide field imaging. It depends on the situation. Don't do everything, and then you have so much information that you don't know what to do with it. I think that is the most important point, I think.
I agree, Aniruddha, it's the case of more the merrier. The more you kind of document, we used to do 55 degrees and previously just 30 degrees of fundus pictures, film-based systems. And now we have 200 degree and we can get actually a montage of 220 degrees. So that covers almost like 85% of the fundus view, and you don't miss any pathology. So a question, if I put it, Partho, is this: should anybody manage a case of posterior uveitis if it doesn't have a facility of imaging? Be it a simple, straightforward, a fundus picture, a fluorescent angiogram, or ICG, or OCT, or OCT angiography. The sky is the limit. So that's the question. So what are those kind of posterior uveitis which you can manage without having to document? And I think Aniruddha has given you ample examples like toxoplasma, which is basically a clinical diagnosis. So is acute retinal necrosis, which is a clinical diagnosis. So I think there's no doubt that if you are the primary care provider, I think you need to initiate the treatment if you're clear about your diagnosis. But if you are not very sure what you are seeing, then I would say that please don't at least start, corticosteroids, because it needs emphasis again that we need to emphasize the difference between retinitis and choroiditis and retinochoroiditis, of which a very elegant example was shown by Aniruddha, that toxoplasma infects the choroid secondarily, and till date we don't know whether toxoplasma actually goes into choroid or not. or is it localizes there and it's a more like an immune response in the choroid? So we don't know, and that's why we need to give them corticosteroids as well, after initiating the anti-toxoplasma treatment. And at least this much primary care ophthalmologist should do that. Yeah.
So I just like to add one thing, that if you don't have the equipment now, there are these iPhones available which have the fitting that you can do for at least. So if you have a blinding disease, let's say retinitis, you can have that iPhone attachment. At least try to get some image, even if it's a faint image of the retinitis, because sometimes if I am a clinician and I have a patient treated with some steroids, some antibiotics, and comes to me with a distorted picture, at least I have access to the initial manifestation. So this is something that we all can probably do. If you cannot afford to have something in the clinic, then at least get those iPhone attachments or, those attachments.
No, that's a great idea. The question is not a challenge for a person who's practicing or who has a significant number of patients of uveitis coming to his practice or our practice. Question is about people who focus, and majority of ophthalmologists world over focus only on anterior segment and that cataract. They feel rather disinclined to test even the pupillary reaction, what to talk of dilating the pupil. They don't have the time or patience to dilate the patient and see behind. Okay, which hypothetically, logically and otherwise, they must dilate and see every patient they are going to do the surgery on. And they, but here we need to change that mindset of anterior segment surgeons, that they ought to see for a number of disorders, right from AMD and retinal issues and diabetic retinopathy and stuff, that they ought to start seeing the retina. And once they start seeing, I think they will realize that it pays to have imaging utility or service or, a tool in their clinic. And be, as you mentioned, a simple tool like an iPhone attachment, or maybe more sophisticated, and these days, the way I see the change has occurred or has happened in India in the last 20 years, ever since the digital technology came and became widespread, that people have started documenting pathology very nicely at all levels. Even the small town people, ophthalmologists practicing there, now they have good imaging facility. So they ought to document them.
Point very well taken. I think another important point is that deciding the treatment with the oral steroid, especially in cases with exudative retinal detachment. No? So one should do fundus fluorescent angiography, because sometimes they may miss the CSR as some uveitic entity. So where the treatment will be paradoxical. If they treat with oral steroid, it can increase the CSR. So that is, I think, another important point where in exudative RD, the imaging is very much essential. So coming to our next question, the next question is from Dr. Pradeep, who asked, how frequently do we need to repeat an OCT scan in patients with CME secondary to uveitis on follow-up visits?
So who should answer that?
You should. Go ahead.
So usually if you have CME, if it is related to intermediate uveitis, I think the primary manifestation is CME. So mainly every visit, at least initially till you have resolution, I would do it probably every month until the OCT stabilizes for a suitable time enough. But if it is an entity, for example, birdshot disease, if availability or if cost is an issue, I could space it out till my immunosuppression is acting. But nowadays, OCT is so easily available, and it's non-invasive, very easily done, does not need dilation. So I don't hesitate in getting an OCT scan in every visit, but there's no point getting it like every alternate day or every week. There are patients who come, for example, I have one patient of viral retinitis, which is resolved and now has CME. And they are being subjected to an OCT every 2 weeks, which is probably an overkill. So I think we should balance it out.
So how frequently you want to monitor this patient? Let me put it in this way.
So for this particular situation, I would like, if I'm starting a new treatment, I would give it at least 3 to 4 weeks if it is not vision threatening, and then assess accordingly.
I have had a different take on the follow-up. Again, this is a case of more the merrier. If the patient can come back, I would like to see after, if I start somebody on 60 milligram prednisolone, okay, and I call him after 2 weeks. So I'll just tell you the instance of a patient who was referred to us with the ischemic optic neuropathy and had been put on oral corticosteroids. We looked at the fundus, we looked at the slit lamp, we got the perimetry done. It was altitudinal field defect. It went with the diagnosis of ischemic optic neuropathy. And but he had these cells, which we neglected and called the patient, as you said, after 2 weeks of starting oral steroids. And what happens when he comes after 2 weeks, he has 360 degrees acute retinal necrosis. So 2 things happened. Ischemic optic neuropathy will not have cells. The second is that herpetic retinitis or herpetic retinopathies, they can have optic neuropathy or optic neuritis. Third, if you don't really do indirect ophthalmoscopy, you might miss out. So on that day itself, probably he had a peripheral necrotizing retinitis and we failed to pick them up. So, I would like to see the response within a week or maybe even earlier when you're starting a patient on something which would alter his life. It's a life-changing experience. 60 milligram prednisolone, I'll not let him lose. And I want to look at all his parameters. I want to look at how is he responding, not responding. If it's a sight threatening, if it's sitting next to the fovea, I want to see him early. Is he going to lose vision or is not going to lose vision? Another instance I had when I saw a patient of vasculitis, and this guy had been taking corticosteroids, from somewhere else in Delhi. And when he came and I got his test done, and he had very highly positive for tuberculin skin test, and his, I told him that we need to give you anti-TB drugs. I wrote that and I told him to continue our corticosteroids. He stopped that corticosteroids. And next time when he came, I have never seen more paradoxical reaction bigger than that. He had all over, apart from vasculitis, which had flared up, he had the serpiginous-like choroiditis, multifocal, involving every part of the retina all the way. Unfortunately, that patient went on to, because we had to give now very heavy dose of corticosteroids, he went on AVN of both the hip joints. So that's an experience where you have to make sure of the compliance of the patient. So you need to see the patient early in the follow-up, so that you make sure that the patient has followed your instructions, and because sometimes we give it, take it for granted that patient has understood everything, and that's the case. Okay.
Thank you, sir. So I have another question. In a patient presenting with vitreous haze and clinically a choroidal mass lesion on an OCT, how do we differentiate a choroidal mass, granuloma versus malignant lesion versus metastasis?
Okay.
So the inflammatory reaction vitritis with a metastatic lesion would be unusual, absolutely exceptional. I don't think there will be a vitreous reaction. Yes, you can have vitreous reaction in patients of, lymphomas. The vitreoretinal lymphomas will have vitreous reaction, which is very, very recalcitrant. And we have burnt our fingers. We have learned from our own experience that these are the patients where you have to be a little more aggressive. Okay. Choroiditis, as I had said in my lecture also a couple of weeks ago, that choroiditis produces inflammation, but not as significant inflammation as would be seen in patients with retinitis, like particularly toxoplasma and viral retinitis or syphilis, particularly immune recovery, uveitis kind of setting. You would see a lot of vitreous haze. But choroiditis per se would produce a minimal vitreous reaction. Yes, there would be inflammation, but not as significant to obscure the details, or that you're not able to do OCT or not able to do fluorescein angiogram and all. So the melanomas, they'll come with vitreous hemorrhage occasionally, but melanomas are rare, and I'm sure you can diagnose them on ultrasound. You can, it's very easy to do. So there's no vitreous reaction per se or inflammatory reaction apart from a vitreous hemorrhage, which sometimes these patients with choroidal melanoma. So I'm not aware of any other, apart from primary vitreoretinal lymphoma, whether there would be any malignant issue. Secondly, if there is any doubt whatsoever, whatever may be the pathology, I would, as a retinal surgeon, I had zero tolerance for something which was going on in the eye and I didn't know what was going on. I would go in with a small gauge, 25, 23, 27 gauge vitreous surgery, clear the media, see the patient on the table, how the retina looks like, what it looks like, and then you can, and in our own experience, which I reported, so is Soumyava Basu's experience, he has reported now, and we had a large series, where we found that actually clearing the vitreous in these kind of situations helps to improve the vision, helps to cut down on the corticosteroids substantially. The immunosuppressive therapy is substantially cut down, and we did not see any patient worsening, except that you have to take care that you need to suture your leaking ports. So hypotony, 1% in my experience was a rare complication, which we did not take care of the ports at that time. But I would go in and settle the issue forever. Do have a good cytopathologist with you, like Jyoti Biswas, who would give you. But these interventions are done only where all the facilities are available, where these are referred cases, and I would not suggest, primary care setting.
I'd just like to add that there are no head-to-head comparisons of OCT of a choroidal granuloma versus a choroidal mass. The choroidal masses can be very heterogeneous. So I don't think you can just depend on OCT alone, if that's the question, because the OCT, the metastatic lesions and masses can be of different origins. They can have different cellularity, and they cannot be differentiated on OCT alone.
No, I would rather do a fluorescein angiogram, which will have a much better, science on fluorescein in metastatic disease.
Yes.
I'd like to add one point. I had read, I think recently, about a choroidal metastasis. So they have this plateau-like elevation of the RPE, unlike the rounded elevation that you see on granulomas. The metastatic lesions, they have a plateau-like elevation of the RPE, and they have this shaggy photoreceptors. So that is something that might help in differentiating a choroidal granuloma from a choroidal metastasis.
Yeah, true.
One point is that I find OCT is quite helpful in post-fever retinitis, particularly subacute sclerosing panencephalitis, where you see the loss of retinal tissue. And that are the situations where if you have got doubt, you can do an OCT, can be of good help.
Absolutely. Absolutely.
The rare diagnosis, but is a life-saving diagnosis, a life-threatening disease.
Thank you. Thank you, sir. Thank you. Over to you, sir.
I think we have come to the end of the very interesting discussion and very interesting topic for today. Any concluding remarks, Amod, Gupta, sir? JB, sir?
I think it's amazingly good images and discussion by Aniruddha. He has summarized his lifetime experience or what is reported in literature. It's all available there. And we learn it every day from his publications, the new breaking grounds, specifically differentiating, various variety of retinitis lesions and, differentiating choroidal granulomas, TB and sarcoid, which often confuse people, and specific signs. I think world over now, people are following those signs of toxoplasma, posterior haloid, those kind of matted deposits of exudates. We have all seen them, but we have not put them into a formal, sign. So is in the post-fever retinitis like dengue maculopathy. And so I think he has covered fairly large ground. And I wished he would speak more on OCT angiography, where there's a lot of confusion as yet, and whether he has a last remark on that. Except for choriocapillaries, I'm not sure how much role it plays, because most of the time I think it's showing secondary effects of choroidal granuloma that they have on the choriocapillaries. I may be wrong, I have only a very passing, very, very early experience, when OCTA came into practice. I just maybe 6 months experience with that, not more than that. But these guys do it every day of their life now. So would you like to comment on that, OCTA angiography?
So OCTA in choriocapillaritis like TB and white dot syndromes, like I said, it's very clear. You have the choriocapillaries ischemia, which appear very clearly. In choroidal granulomas, there is usually a mass effect. And because of the mass effect, you have the choriocapillaries, which are not very clearly visible on the OCT angio. And not necessarily there is an ischemia, but this is just a mass effect which is seen on the choriocapillary slab. So in choroidal granulomas, really, I don't depend much on OCT angio. And OCT is usually the imaging modality of choice. One thing that I did not cover is MUDES. And in MUDES, this is an entity where on the OCT angio, you have completely normal appearance, whereas ICG will show you hypofluorescent lesions. So this has led to us to believe that MUDES is a photoreceptoritis. Probably the choriocapillaries are normal. And this is where OCT angio plays an important role in identifying eyes with MUDES, differentiating it from MPE and other white dot syndromes. And I think in PIC and multifocal choroiditis, OCT angio is very, very important in detecting subclinical neovascularization. So if you have access, you should do OCT angio to detect subclinical neovascularization.
Absolutely. I think that's the greatest contribution in posterior uveitis, if there is one.
Yes.
Because that can't be imaged with anything else,
No.
Nothing will help. So only OCT angiography will help you pick up these cases. And this complication of C and V is far more commoner than people believe.
Yes.
We are seeing much more common than
than it was earlier believed to be.
Yeah.
Well, thank you very much.
Even in diseases like Behçet's and post-fever retinitis, where you can see the capillary non-perfusion in the superficial vascular plexus. So
yeah, you can see, in several diseases, you can see the capillaries being affected. I don't usually do it, but to be honest, because I don't find much therapeutic. There are publications you can quantify, you can do it for research purpose, but in clinics, I don't usually apply it.
Is it not useful to explain the visual prognosis? Like some patients in post-fever retinitis, they have this BRAO, and you see that there is a lot of macular ischemia, and that could.
Sure. You can use even fluorescein, for example, or you can use even OCT imaging to show the outer retinal atrophy. I don't necessarily depend on OCT angio. Yes, if you have an image, it's the best to show to the patient that you have actual loss. But the point is, you can use other tools as well. OCT angio gives you a very good delineation. There's no doubt about it. But in my practice, I don't apply it every time.
I think with this, we can call it a night.
Thank
Thank
you.
you so much, Amod sir, Jyotirmay sir, Parthopratim
Thank you.
sir, and
Thank you.
Abhilasha ma'am for being there every single week. I think Uvea module is going to be one of the most viewed module because it's such
For sure.
interesting discussions happening here week after week. Thanks to all of you. And thank you so much, Aniruddha sir, for sparing your time with us for that very, very interesting talk. We hope to see you for the discussions also. You're always welcome, sir, on the iFocus online platform for the discussions. So next we'll meet on 28th December. The topic is Complications of Uveitis by Dr. Arshi Ahmed. And also I have the announcement for Physical Eye Focus, which will be in New Delhi from February 26th to March 5th. I think only 8 days are left for our delegates to register. You can register on the link given here. So don't delay. I'm sure you don't want to miss it. Like all of this happening live, I am very sure you don't want to miss all this. So thank you so much, everyone, and have a very good night. See you on Wednesday.
Thank you. Thank you, Andrew.
Thank you. Thank you.
Thank you, Debbie. Thank you, Partho.
Thank
Bye.
you.
Thank you.
Thank you.
Thank you, sir. Thank you, Aniruddha.
Thank you, ma'am, for being here.
Bye.
Bye, ma'am. Good night.
Bob can rest now.
Yeah, Subham needs to sleep. Bye, ma'am.